Good morning. I'm Denise Wilson, the president of Tri-State Brain Aneurysm Support Group. I'm honored to welcome you to today's event. This is our 15th annual and first ever virtual Brain Aneurysm Symposium. We know you could be doing any number of things today, and we are honored that you have chosen to spend part of your day with us. We have assembled a terrific lineup of speakers for you, and I'm certain that you will find their topics and discussion interesting and insightful. We do have a slight change to the speaker lineup today. Dr. Prestigiacomo unfortunately will not be able to join us, but Dr. Smith will be presenting in his place and will be speaking on headaches, an always popular topic with our group. We invite you to ask questions during this event by using the chat feature. Our moderators will receive your questions and hold them until the appropriate time. Each speaker will allow a time for questions and answers at the end of their presentation. Before we get started, I'd like to take a few minutes to share with you some exciting things going on at the Tri-State Brain Aneurysm Support Group. Our mission is to provide information, education, encouragement, and understanding to survivors, caregivers, and those who have lost a loved one to brain aneurysm. We also work tirelessly to raise awareness in our community about issues involving brain aneurysm. Did you know our board of directors and steering committee are made up of people much like those we try to help? We're survivors, those living with an unruptured aneurysm, caregivers, neuroscience intensive care nurses, occupational therapists, and those passionate about helping individuals after brain injury. In fact, my husband Joe suffered a ruptured brain aneurysm in April of 2015. At that time, we had never even heard of a brain aneurysm, and we certainly didn't understand what he was facing. We had more questions than answers and didn't know where to turn for help. Joe described what he had experienced as the worst headache of his life. We had just finished a 5K, and Joe was driving home when he started experiencing a headache, blurred vision, sweating, and nausea. Just after Joe pulled the car down our driveway, his aneurysm ruptured. He got out of the car and collapsed. Our neighbor called 911 and paramedics responded, checked Joe out, but left our house and said he was dehydrated from the walk. After a few minutes, I knew something more serious was going on. I managed to get Joe to our local ER, and within an hour, I'd been informed he had suffered a ruptured brain aneurysm. He was transported to Good Samaritan Hospital in Cincinnati, and within minutes, treatment had begun. The doctor at Good Sam told me that Joe would likely not survive the night and suggested we call in the family. It was a very trying time. After 5 weeks in the hospital, 3 in ICU, and 2 in inpatient rehab, endovascular coiling, and more procedures than he can remember, Joe came home to continue his recovery journey. It wasn't easy, it wasn't quick, and it's still ongoing today. Joe has good days and not so good days, but he's thankful for each day God has granted him. Joe and I have been serving on the Tri-State Brain Aneurysm Support Group since 2018, when Joe's neurosurgeon, Dr. Andrew Ringer, suggested we serve to share our story and continue bringing awareness to this life-changing diagnosis. Thankfully, we had a happy ending due to the incredible care Joe received at Good Samaritan Hospital, and we are forever grateful for his Mayfield brain and spine doctors. In fact, 2 of the doctors who treated Joe will be our guest speakers today. We know that 2020 was a challenging time for many, and 2021 hasn't been easy either. We've faced illness, isolation, and insecurity. Life as we knew it changed, and our new normal was being redefined each day. Here at the Tri-State Brain Aneurysm Support Group, we quickly learned we needed to adapt and be flexible to continue serving those who need us. During these uncertain times, it was more important than ever. To do this, we rebranded ourselves with a new logo, a new website, a YouTube channel so we could more effectively communicate with our members. We moved to virtual monthly meetings, support group meetings, and we began posting those recordings when possible so those not able to attend could still view them. We held our first ever virtual walk in September of last year, and our turnout was tremendous. We started using Facebook and Instagram more regularly, and just recently, we created a LinkedIn presence. I encourage you to follow us if you don't already. These social media outlets are where you will find the most up-to-date information about our happenings, our monthly support group meetings, and our special events. If you'd like to be on our mailing list, please sign up at our website, tsbasg.org. We're working on a few other exciting things you'll hear more about soon. One that I'm very proud of is our Medical Advisory Board. While we cannot offer medical advice to our members, we are teaming up with the best of the best to bring you answers to the questions you have. And in light of recent CDC announcements, we're working on a hybrid offering for our monthly support group meetings. We've heard from many of you that you like being able to attend the meetings virtually, and some of you are not able to get transportation to attend in person. And we also know that some of you prefer in-person meetings for the camaraderie. We hope to have a solution soon that will meet everyone's needs. We do hope to return to in-person meetings as soon as possible, although your health and safety is our #1 priority. We have many more things planned for 2021. In July, we'll be hosting a virtual yoga class. And of course, on September 25th, we will host our 8th annual 3K Brain Aneurysm Walk for Awareness. Mark your calendars, it's going to happen. We hope to be in person, and if so, it will be held again at Fernbank Park, which was the location of our 2019 walk. We'll let you know as soon as more details come. November will also be our very popular topic of navigating healthcare bills, which you won't want to miss. And in December, we're very hopeful to be back in person for our annual holiday social. According to the Brain Aneurysm Foundation, an estimated 6.5 million people in the United States have an unruptured brain aneurysm. That's 1 out of every 50 people. About 30,000 people in the United States suffer a brain aneurysm rupture each year. That means a brain aneurysm ruptures every 18 minutes. I'd like to ask something of you. If you're comfortable sharing your aneurysm story with us, we would love to hear it. Please send us an email at tristatebrainaneurysm@gmail.com for more information. We'd like to encourage you to never stop sharing your story. This is what helps with awareness. No matter how long ago it was, it still has significance. And you never know who your story may reach or when it might save someone's life. I know you didn't register to listen to me all morning, so without further delay, I'd like to introduce you to our next speaker, Dr. Jonathan Hodes. He's a doctor with the Mayfield Brain and Spine. Dr. Hodes will be speaking about pre- and post-op imaging of brain aneurysms. I just recently listened to an episode of Simply Medicine with Anjanette Levy on 55 KRC. Anjanette interviewed Ron Murphy, the Public Information Officer for the City of Norwood Police Department. I'm sure some of you may remember this story from our local news recently, but Ron was delivering a check to a family of a fellow officer who was in the hospital with COVID. Just a typical day as he described it. He had a headache, but pushed on. On his drive home, he felt nauseous, had blurred vision, sensitivity to noise and light, and pulled his car over to call his wife. Thank goodness he did. His wife, with the help of some quick-acting folks, was able to locate him and send help his way. Thankfully, he was treated within a few hours of his aneurysm, and that can make all the difference in the world. At that time, he had no idea he was in for the fight of his life. Enter his Mayfield Brain and Spine doctor, Jonathan Hodes. Jonathan explained the rare condition Ron had and how he treated it. Today, Ron is doing well in his recovery and working hard to get back to enjoying the things he loves. These stories never get old. Dr. Hodes, thank you so much for joining us today.
Thank you so very much. What a wonderful organization to be able to present to today. I thank you so much. Today, I'd like to discuss with you the pre- and post-operative imaging of brain aneurysms, which is really key to the ability to treat these. So we're going to break this down into 4 parts. We'll discuss the kinds of imaging that's done, cerebral angiograms, computed tomographic angiography, magnetic resonance angiography that are called CTA and MRA, what we do for aneurysm screening, surveillance of aneurysms once one has been found, and post-operative imaging. Let's start a little bit with a discussion of the anatomy, which is key to delivering blood to the brain. So the blood supply of the brain is divided into an anterior circulation, which comes from the carotid arteries, which are the blood vessels that you can feel in your neck, in the front part of the neck on either side, and the vertebral arteries, or the posterior circulation, that run in the vertebral column in the bones of your neck, going to the back part of the brain. And there's a connection between these two systems that goes through the circle of Willis. Dr. Willis described this in 1642. And there's a posterior communicating artery. There's the anterior communicating artery that connects the right and left sides. And the posterior circulation comes up into a single artery that divides into the posterior cerebral arteries, which are all connected, so that if one of these main arteries, either carotid or one vertebral artery, or even both vertebral arteries are blocked, there's still enough blood to get up into the brain very frequently. The 2 vertebral arteries form one artery called the basilar artery, which is a frequent site of aneurysms. And the carotid and the vertebral arteries, they connect at the circle of Willis. So these are names that people with aneurysms and in this community may be aware of. The anterior communicating artery is located between and behind the eyes, and that's a frequent location of aneurysms. The middle cerebral artery is in the mid part of the brain, and thus it's named the middle cerebral artery. The posterior communicating artery comes off of the internal carotid artery, and that's a frequent site of aneurysms. And then the basilar artery, superior cerebellar arteries, posterior cerebral arteries. And aneurysms tend to occur at the junctions or the bifurcations that occur in these locations where the blood flow is being divided and is most turbulent. So the imaging of blood vessels includes catheter angiography, where a contrast dye is injected into the bloodstream, and then a movie is taken of that blood moving through the blood vessels. CT angiography, where a contrast dye is injected into the veins that then returns to the heart. The heart pumps the contrast into the arteries, and the arteries are imaged rapidly. And then using the magic of computers, an image is created that can be rendered in 3 dimensions and rotated in lots of different directions. And magnetic resonance angiography, where the liquids in the head can be aligned with a very strong magnet and then allowed to relax, and the different relaxation times of those liquids can be imaged, and you can actually differentiate between blood vessels, between veins, between brain tissue, white matter, lots of interesting things. And these images give us a very distinct picture of the blood vessels themselves. So the internal carotid artery angiogram is seen here from the frontal projection. So a camera is placed facing your face, and from the side, or lateral projection, and a blood vessel is injected and the movie is taken, and then still pictures are used to be analyzed. And this actually shows subtracted coils in an anterior communicating artery aneurysm. And the vertebral artery, which one vertebral is ejected, but because it merges with the opposite vertebral artery into the basilar artery, oftentimes there's reflux down the opposite side, so you may just need to inject one of the vertebral arteries in order to be able to see both inside the head. And from the side, we can visualize the posterior cerebral arteries and junctions of the posterior cerebral arteries, obviously looking for aneurysms, and the posterior inferior cerebellar artery, which is also a fairly common site for aneurysms. And then we can do a rotational angiogram, and here we see the angiogram itself and then a reconstruction where there's a middle cerebral artery aneurysm seen here. And on this one, there's a basilar artery aneurysm that's identified. And you can also see that this patient's had a craniotomy, because we can see the little telltale signs of the little tiny plates and screws that are used to hold the bone in place, and the metallic clips used to clip other aneurysms that were present previously. So how's an angiogram done? Well, let's talk about that a little bit. First off, you're awake, and the patient is awake, but given what I call kickapoo joy juice, so that there's little memory of the procedure itself. A long, flexible catheter is inserted into the artery in the groin, and then the catheter is moved up through the aorta, past the heart, into the blood vessels leading to the brain. And here, this is into the left carotid artery, the little catheter. When the catheter is in the correct position, contrast is injected and X-ray pictures are taken. And when that happens, there's a sense of hot flushing feeling, and that can be somewhat uncomfortable, though not always uncomfortable. And that lasts a short period of time. While that dye is being injected, a series of pictures, basically a movie, is being made of the contrast circulating through the blood vessels that then can be analyzed to look for aneurysms, vascular malformations, irregularities of the blood vessels, etc. After that single blood vessel has been injected, the process is repeated to view all of the arteries that are needed in order to visualize the intracranial circulation. So you hear about catheters and wires. So what this is, there's a guide wire that's used, which we haven't, well, you'll see that in a minute, a catheter, and then oftentimes a microcatheter can be used from inside of this catheter in order to get more distally into the aneurysm or into specific blood vessels. Now, I'll caution you that the video you're about to see is a real procedure, and there's blood and needles, so if you don't want to watch that, just don't watch it. So in the angio suite, the patient is placed on their back, and the groin area is prepped. So we've sterilized that area. The C-arm is then utilized, which is a X-ray detector. The X-ray machine itself that generates the X-rays is below the patient. And then a pump is used in order to inject the contrast at a specific rate and volume. Here, the physician is feeling for the pulse. And after local anesthesia, a small nick is made and the blood vessel is accessed, and a little wire is placed into the artery. The goal is to go through one wall of the artery so that there's little invasion. And here's the catheter and a guide wire coming out that we can see there. This is advanced through the femoral artery, past the aorta, past the heart, and we watch that. It's kind of like a video game because we're watching this on a screen and just using little tiny movements. And here's a X-ray picture of the aorta, of the catheter, and then it's going up into the carotid artery here. You can see the dye being injected just to access the artery. And here are the catheters placed. And then we ask you to hold your breath and not move or breathe or swallow. And then the X-rays are taken. And here's the anterior projection with the dyes circulating through, and that's a movie. That gets analyzed. And so here we see the picture, both in the anterior and the lateral projection. And we'll go through that again. We can stop it. And so we can stop it at any point and see the different phases of the contrast. So there's the first phase of the contrast that shows the arteries. So this is the arterial phase, and they're very well opacified. The internal carotid artery that bifurcates into the middle cerebral artery, right here, into the anterior cerebral artery. And these are the branches of the anterior cerebral artery coming, and the middle cerebral artery. And the same thing, the anterior cerebral artery, and then the middle cerebral artery, and this is the posterior communicating artery to the posterior cerebral artery. And then once you get to a little further along in the movie, we can look at the capillary phase, where these are the tiny little blood vessels that irrigate the brain itself. They're as thin as a cell of blood. And so the oxygen and nutrients that are carried in the blood diffuse through these tiny little blood vessels into the brain to give nutrition to the brain and oxygen to the brain. And we're seeing the arterial and then the capillary phase here. And when we go a little bit further, we start to see the veins. And the veins drain the brain after that blood has circulated, and they come down into the sinuses, which are seen here, which are large vessels. They come down into the jugular vein, and return to the heart this way. So you have a arterial, capillary, and venous phase, and each of these are analyzed by the physician who's performing the procedure itself. And on this particular angiogram, we identified an aneurysm, which is this in particular is a berry aneurysm, which the ancients would like to describe things for and name them for things that were normally seen in their day-to-day life. And this aneurysm in particular, a berry aneurysm, looks like a berry. And the aneurysm itself has an anatomy. It has a dome and a neck of aneurysm. And once again, in this situation, this aneurysm arises at the bifurcation or the branch point of the internal carotid artery and the ophthalmic artery, or the artery that goes to the eye. In addition, this individual also has a dilation of the internal carotid artery, or an enlargement of the internal carotid artery here, that is consistent with a fusiform aneurysm, which I think of like an inner tube that's gone bad, where there's a swelling within the artery itself that shouldn't be there, that can happen because of a dissection of the artery, where the lining of the blood vessel is torn, the blood enters into the wall of the blood vessel and expands what's called the adventitia, or the outer layer of the artery, causing this swelling or dilation that we see. And this patient had both a Mra aneurysm like this, as well as a fusiform dilation of the vessel. After the procedure, in order to get out of the artery, because these little tubes can cause bleeding, we can use a sealing device. Oftentimes we'll use Angioseal or Exoseal. Sometimes we'll just hold pressure and then place a device onto the artery to hold pressure for 15 minutes to half an hour in order to stop the bleeding. And if Angioseal is used, a little foot plate is placed into the artery that's absorbable, and then collagen is tamped down onto the outer part of the artery that forms a seal and stops the bleeding essentially immediately. Similarly, another device called Exoseal can be used, once again, where a plug is placed and the vessel is closed. So the things that you need to know after an angiogram are that there's a concern for blood loss through this puncture site in the groin. If that happens, usually a large lump will develop, which then will turn into a bruise. It can be, if the bleeding occurs, it can be invisible because it can track behind the peritoneum, or the potential space surrounding the guts, and that can cause a pain in your groin or your lower back. If you may become tachycardic, or your heart rate may go up, or you could be hypotensive and feel sweaty and just not feel right. You won't be anemic at first because the blood loss can be relatively rapid. And if you suspect something, once you've gone home, you should apply manual pressure and call the physician. And if there's a suspicion for internal bleeding or retroperitoneal bleeding, then a CT scan will be obtained, and then treatment would ensue. So a concern is, after the procedure, whether or not that could occur. This happens extremely rarely, less than 1% of the time. So we've talked a little bit about angiograms, CTAs, and MRAs. So let's talk a bit about aneurysm screening and how we do that. So 1 in 50 people will develop a brain aneurysm at some point in their life. And some aneurysms can be familial. About 2.3%, 2.5% of the general population has or will develop a brain aneurysm, which is about 6.5 million people in the country. Of those, 15% have multiple aneurysms, and most aneurysms are not hereditary. Most of the time, it's just, it occurs because of a weakening of the vessel. Aneurysms that occur, however, in 2 or more first-degree relatives, and a first-degree relative is a sibling, brother or sister, a parent, or a child, are called familial aneurysms. And you can go to our mayfieldclinic.com/aneurysm-checklist, and you can look to see whether or not you might be considered at high risk or moderate risk or low risk of an aneurysm. So some people can have multiple aneurysms, and I had the opportunity of treating a young man who had ruptured an aneurysm, had a subarachnoid hemorrhage. Turned out that he had 3 cerebral aneurysms, and because of the rupture, we were unable to determine which aneurysm had bled. So at the time of bleeding, I went ahead and treated all 3 of them endovascularly with coils. And here is a post-operative angiogram, 3-dimensional reconstruction that shows the coils in silver in the aneurysms, and then the blood vessels being open and patent, and the patient did very well. About a year later, his sister presented with ruptured aneurysms that were not amenable to coil treatment or endovascular treatment, and she underwent successful craniotomy and the discovery of 2 aneurysms, which were clipped successfully, thankfully, without too much trouble. So should your family be screened? So the prevalence of aneurysms is that 4% of 4% of people with 1 affected first-degree relative will also have an aneurysm. And if you have 2 affected first-degree relatives, say dad and sister, or child and brother, 8% of those people will have a cerebral aneurysm. So it's clearly, under those circumstances, it's appropriate to be screened. And then if you have certain risk factors that are modifiable, like a history of smoking or continued smoking, or hypertension, high blood pressure, then up to 19% of patients can have a cerebral aneurysm. And familial aneurysms, if they occur, also rupture more frequently. So if you have 2 or more first-degree family members with an aneurysm, or polycystic kidney disease and 1 family member with an aneurysm, then we recommend screening. And there's an increased risk of rupture if you smoke, if you're female, if you have high blood pressure, or you use any medications or drugs of abuse that increase blood pressure, like cocaine, or if you drink excessively. So depending on your family history and risk factors, screening with MRA, which is non-invasive, is usually done every 5 years because aneurysms can develop. So aneurysm surveillance. What do we do if we do find an aneurysm? Not all aneurysms need to be clipped, which is beyond the scope of this talk. So with MRA aneurysm surveillance, we would go ahead and do an MRA and look for aneurysms and look for any changes that can occur in the aneurysms. If there's a change that occurs in the aneurysm, or the aneurysm is of a certain size, then we would consider, depending on the anatomical considerations and your age and medical condition, we would consider a surgical clipping of the aneurysm, where an aneurysm clip is placed directly onto the base of the aneurysm. The clip is closed in order to exclude it from the cerebral circulation and thus prevent bleeding, and endovascular coiling from within the blood vessel. Aneurysm surveillance, and the size remains stable. An MRA is done every 6 months for 2 years, and then once a year for 3 years. And if after 5 years there's no change in the size, the risk of rupture is considered to be very low, and you decide with your doctor how often you want to repeat the aneurysm. Growth, not size of aneurysm, is the biggest risk of rupture. So here we have a CTA surveillance that was accomplished in 2000, 2001, 2002, and there is evidence of growth of the aneurysm. First, the aneurysm is seen here, not too big. So it's not something that we would primarily consider treatment of. And at 2001, there's a hint of a change in the configuration of the aneurysm and its size. In 2002, the aneurysm is increased in size clearly, and treatment was felt to be indicated. So post-operative imaging, we want to confirm the clip or coil placement, and we confirm that no blood flow is entering the aneurysm, that the parent vessel is not occluded, and there's no significant coil compaction or neck recurrence. And so there's an aneurysm identified, it's filled with coils. After there's a surveillance MRA shows a MCA aneurysm that increased in size. The angiogram done demonstrates the anatomy of the aneurysm, which is most favorable for clipping. An aneurysm is clipped, and post-clipping, we can see the coil, the aneurysm clip, and no evidence of aneurysm recurrence, and just a skull film showing the aneurysm clip. And post-operative imaging is accomplished if it's ruptured and embolized, then a follow-up angiogram at 3 months, 6 months, and yearly for 3 years is recommended, then MRA or CTA imaging. If unruptured and embolized, follow-up in 6 months and yearly for 3 years, then MRA or CTA imaging. If a vessel flow diverter is used, then every 6 months until gone, and if it's clipped, a 3-month and 1-year angiogram, and then MRA or CTA imaging to look for other aneurysm development. So post-operative imaging showing this shows confirmation of no flow within the aneurysm. Aneurysm, flow diverter, no flow. And at times there can be a little bit of a coil that comes into the neck. So we want to watch for any thrombosis or changes that occur there that might require treatment. And at times the coils can compact. So after the embolization, there's a little bit of residual neck. And then at 6-month follow-up, there's been recanalization. So, or reopening of the aneurysm, and therefore it's necessary to consider further treatment. And finally, at 2 years following treatment of a ruptured aneurysm, initially there's complete obliteration of the aneurysm. We can't see any filling of the aneurysm, and the bleb or Murphy's teeth that we think most likely was the source of bleeding is completely blocked. And then a couple of years later, there's some recurrence of blood entering into the aneurysm near the neck, so consideration of retreatment is appropriate as well. And sometimes we'll do a operative procedure and we can see the coils in the dome of the aneurysm, compaction of the coils, and then this is at surgery, a clip can be placed in order to prevent rebleeding. And to reduce reduction, we want to use several strategies to induce fibrosis into the aneurysm. We want to cover the neck. That's the most important thing. We use a couple of different kinds of coils that have a bioactive substance or a gel that fills, and that can help prevent recurrence. Or we can place a stent to get more coils at the neck, or a flow diverter that is more woven, which is a more woven stent that prevents blood flow into the aneurysm. And I have gone over a little bit, I apologize, but that we have.
I thought that was great, Dr. Hodes, and very clear. Thank you for that. We do have some very good questions. So here is the first one. How do you get past the heart with the catheter?
So we don't have to enter the heart. The aorta is a very nice pipeline that takes us from the groin right past the heart into the blood vessels leading to the brain.
Well, that is good news. Are there long-term side effects from the dye that is used?
No, there are risks of the dye. So we screen beforehand to make sure that the kidneys are working well and that there's been no reaction to the dye in the past. And as long as there isn't, then we can just go ahead and use the dye. If there is some kidney problem to begin with, we can use some medications to reduce the risk of damage to the kidneys. And we want to make sure that you're well hydrated beforehand. So an IV is started, and we want to give you lots of fluid, and then afterwards fluid is given in order to flush the dye out of your system. We recommend drinking a lot of fluid afterwards to help flush that out.
Okay, that makes sense. Can the stent ever move?
No, once it's placed, the stent does not move.
Okay.
During the placement of this stent, we're very careful to put it in the right place.
Here's another one. I just recently found out that the metal in my brain is not compatible with all MRI machines, that I'm only safe to be in a 1.5 Tesla machine, not a 3.0. Can you reinforce to listeners the importance of patients having a copy of their implant log and knowing which type of machines they are safe to be scanned in? Thank you.
I think that's a great idea. That's a really good point. At this point, most of these devices that we use are compatible with all MRI machines. Many of them are not specifically rated because the higher Tesla magnets were not in existence when these devices were approved.
Mm-hmm.
And so you're likely safe, but it's best to stick with the manufacturer's recommendations. And so it is important to have a implant card so that you know what you have in your head.
Okay, well, that is some great advice. That's all of the questions that we have for right now. So thank you so much for your time, Dr. Hodes.